Like Chris said, I am a third-year vet student over at Kansas State University's College of Veterinary Medicine, or CVM. You might hear me say that, CVM. For the Veterinary Health Center, VHC, you'll hear me use that abbreviation as well. So just so you know what I'm talking about. Um, so a little background on the Veterinary Health Center. So it was established in 1906. It's a 185,000 square foot facility. The staff includes 55 senior clinicians, but then of course on top of that, there are residents, interns, lots of students running around, as well as nursing staff, etc. And we provide treatment for over 23,000 patients per year, and that's all around the Midwest region. So the VHC provides a number of services. It's split into small animal and large animal. So for small animal, that can actually include exotics as well, large animal, horses, and then also an occasional zoo animal, which can be pretty fun. We also do specialty services like oncology, dentistry, ophthalmology, etc. So the incentives for change for the vet health care facility, we are basically following in human medicine footsteps. They've kind of tried to make a stride to improve their hospitals in terms of sustainability, and VetMed's a little bit behind, but we're trying to catch up a little bit. But the KSU-CVM in particular is pretty ahead of the curve, I would say, because we've instituted a sustainability certificate program. And a part of that are sustainability electives that they've fit into the curriculum as well, which has not happened at very many universities. So it's pretty cool. So this is my project summary for the projects that I worked on for this internship. Sharps Container Project, Anesthetic Projects, and Central Prep Project were my big three. So these three projects fall under pollution prevention, mainly in terms of source reduction. And for sharps, there's a decrease in containers, orders, and disposal. Anesthesia, there's a decrease in anesthetic orders and release into the atmosphere. And with the Central Prep Project, decreased power and water usage. There's also an education component that's also important to the P2 process in each of these as well. So first I'll start with the Central Prep Project. And I will just say there's a lot to look at. So Central Prep kind of is the place where everything's dumped to be cleaned and then put out into the hospital, as well as provide supplies. And there's just a ton to look at. We narrowed it down to just one project within Central Prep, but if there's an intern again next year, I'm sure they could find others. The Central Prep layout is split into two different rooms. There's a dirty room and a sterile room. The dirty room is obviously where everything that's been used gets dumped in there and is cleaned before it goes into the sterile room. So the project that we were looking to improve upon was in the treatment of biohazard bags. Basically, what the process is now, as it's laid out in this little figure, is that the biohazard bags are collected in the dirty room. They're taken straight into the sterile room, and they're put in the autoclave cycle before they return to the dirty room, where they're then washed and then dried separately. So what are the current recommendations for biohazard bags in VetMed? Is not to do that. Omitting the autoclave step is actually something that we're recommending, because according to the AAHA, really you just need to do a bleach solution soak for about 10 minutes before putting it into laundry without having to run a full autoclave cycle. And then the Center for Disease Control states that laundry with the agitation and with the high temperature of the water is good to clean and kill most pathogens, especially with the bleach in there. And the only time they recommend the autoclave step first is for NICU and for burn units, where obviously the patient is a little more susceptible. So this chart, well, let me just back up and say our autoclave machine, it's by a company called Getinga, and they're a great company. They were really easy to talk to, but they don't provide a nameplate on their machine for the specs. And then I talked to them, and they're like, well, we don't provide that information at all because it's different for every machine and it's different for every cycle that you guys choose to set up. And the only way to figure it out is to do an audit on all of those, like water consumption and power consumption. So Chris and I researched a bit, and we were able to come up with kind of a pretty conservative number for power use. The Getting a company did tell me that depending on what cycle you have set up, it could be between 5 and 500 gallons of water. So that was just kind of estimate. So in the chart, it's a low end and a high end. And then the average is what I have to show there with the cost savings with omitting that autoclave step, about $900 and 1.4 metric tons of CO2 equivalent. The additional benefit is that although the contents from whatever patient has got into that biohazard bag, although the contents are in the bag is not clean or sterile at all on the outside, and it's been all over who knows where in the hospital. You don't really want that going straight into the sterile room because there's a possibility for cross-contamination, and that's not good. So removing that autoclave step first gives you an opportunity to wash, get rid of as much pathogen as possible, and pretty much all of it, and then not introduce that cross-contamination possibility. Next is my favorite project was the volatile anesthetic project. So I'm not an anesthesiologist, and I don't claim to be. If you have super picky anesthesiologist questions, I might not know the answer, but I'll try my best. But I'll kind of explain the rebreathing circuit. So when a patient is at least 10 kgs, they qualify to be put on the rebreathing circuit. And basically the fresh gas equals oxygen and anesthetic vapor. It's combined and it goes out together. When the patient exhales, it recirculates through the circuit and it gets scrubbed in a CO2 scrubber. And then the gas is actually returned to the patient. So it's continually flowing through and it's recirculating. So in that sense, you don't have to have the flow as high because it's being recirculated in the system. So for vet med, we basically use isoflurane and sevoflurane are the two anesthetic vapors primarily used. This is the cost breakdown. So you can see sevoflurane is quite a bit more pricey than isoflurane. And there is a little bit of a difference between the emissions output for these two as well. So they're both potent, but isoflurane is a more potent greenhouse gas. And you can see 1 pound of isoflurane is equal to 491 pounds of CO2 equivalent, where sevoflurane is a little bit less, but it's 76% more expensive. So that's why isoflurane is typically used over sevoflurane, unfortunately. So what is low flow? I kind of started to explain it. So after the patient is induced and then introduced to gas or vapor, after about 5 to 10 minutes, that can be lowered to just 20 mils per kg per minute. If the patient starts to kind of get light, you can increase it again to make sure they go back down, but it should just be a temporary increase and then right back down. So in order to kind of gather data for this project, we were able to take 10 patients at random, mostly just picked due to legibility of the charts, because as you can see, they're handwritten. So it kind of depended on if we could read them or not. Isoflurane was only anesthetic used in all of these situations. And as you can see, I don't know if I have a pointer. You see my mouse at all? No.
You want to go to the screen and just point there? There you go.
Yay!
Yeah.
Look at me. So as you can see at the top, at 1.5 is the flow meter setting. And then this line right here is the isoflurane percentage that's being popped in. And so as you can see, the flow setting is set to 1.5. The patient's probably doing great, gone down, but then it hasn't been lowered the entire time. That's what we're trying to fix. So based on looking at those 10 records, I was able to get a percentage of a reduction percentage. So let me back up just a second. Sorry about that. So I first looked at all this data, gathered this data, and then I went back and based on the patient's weight, I was able to determine what the low flow setting could be set at. And so then I could do a calculation to determine what the savings would be and what that percentage of savings would be. And then so the average ended up being about a 58% reduction, which is pretty major. Like one of them was about 80%. So, and the lowest being, I think, 40. So that's a huge amount. So that ends up being cost savings annually about $5,000 and environmental savings about 41 metric tons of CO2 annually, just from turning down that nozzle. And there's no, you don't have a cost going into that. It's just behavioral. So we're planning on implementing an educational program as well as using these pictorials that we created and this flow method, the iFlow method that we created to place on anesthesia machines, as well as give students information before they start their anesthesia rotation about the importance of low flow and kind of go through that process with them. And then finally, it's the Sharps Container Project. Last but definitely not least. Okay, so Sharps containers are used in hospitals and sometimes home settings for like diabetes needles and whatnot. And they're important to keep not only the hospital staff safe, but also on the other side, the waste management personnel want to keep them safe as well. So for our hospital, the life cycle, we acquire the containers from MWI. We're obviously the ones to fill them at the VHC. Environmental Health and Safety comes and picks them up and packages them. Sharps Inc. Ships them to their facilities in Oklahoma or Texas. And then possibilities for where they go after that is incineration, autoclave, and then landfill. So this is the cost breakdown for the Sharps containers. And I really just want to point out, so for a 2-gallon bucket, it's approximately $25 for 10 of them. They go into a cardboard box. With the 8-gallon, it's approximately $25 for one of them. And so there's quite a big pricing difference right there. So one of my suggestions was actually to not use 8-gallon ones for a number of reasons, but that was part of it. So I went ahead and did 2 separate audits. There were 2-week period audits, and just to see kind of what people were putting in Sharps containers that were appropriate versus inappropriate. The bag of fluids is inappropriate, and it's basically full, so it's really heavy. And as you saw in the last slide, there's there is a penalty for going over a certain amount of weight, so you definitely want to keep the weight down. So what you want to put in Sharps containers are actual Sharps, things that will poke you if in the trash can, so needles, glass slides, blades, suture needles, etc. So these are the results of my 2 audits. Syringes by themselves without needles attached are a gray area in vet med. Human medicine says to keep the needle attached to the syringe and then put it in a Sharps container. Vet med, based on experience, we tend to disconnect it, put the needle in Sharps container, syringe in the trash. So I did one where all syringes counted as inappropriate, and then I did one where syringes with needles attached were considered appropriate. So those were the 2 differences. But as you can see, it was the same for both audits where empty drug vials took up 31%, and those don't need to be in sharps containers. So what happens to our sharps containers once they leave the hospital? I talked to Sharps Inc., where they pointed me in this direction, and you can see that the sharps contents end up being autoclaved. So similarly to my central prep, it's hard to get autoclave information. So I went with the same standards as the central prep project. But we end up with a savings of about $2,300 just by reducing our content, inappropriate content, I guess, in the sharps containers by about 30%. So if you're reducing the content by 30%, savings of $2,300 annually. And you can see the GHG emission reduction as well. So we went ahead and created this pictorial as well that we're going to place throughout the hospital to have people consider what they're putting into sharps containers and be a little bit more discriminatory about that. The QR code is active, and it takes you to the life cycle of the sharps container and the cost breakdown, so people can see that for themselves if they're curious and want more information. We wanted to use lots of pictures so they don't have to really take time and read. If they're in a hurry, they could just be like, nope, yes, okay. And then lastly, this is my last slide. When I reached out to Sharps Inc. about what was happening to the waste that they were processing through the autoclave, they pointed me here. So is this the future of medical waste? And what they're doing is they're making these little pellets, pellet DRX, that they can then use in raw materials and manufacturing facilities for like cement, lime, steel, and power plants. So I just kind of wanted to leave that there and just see if you guys think that's a cool thing, what your thoughts are about it. I think it's cool, but I don't know if it's actually like working. I would want more information, but just thought I'd leave that there. Any questions?
Well, thank you, Carrie. Do we have questions from the audience?
So, do you know why people put bottles in their sharps container?
A lot of it. So with the bag of fluids, it has to go back to that 8-gallon size again. People see a big container and they just dump it. Yep. Which is another reason why in my report I'm recommending getting rid of those, is because when you have smaller spaces to fill, you don't put more, are more discriminatory of what you're putting in there. And then it's could be proximity to a trash can. Is there a trash can nearby that they know that they can use? Because a lot of times they're in a hurry. They're trying to get things done really fast. And so is there a trash can in there that they can dispose of instead? Is a big thing. And another thing, people just don't know. They're like, oh, like, I don't know, does this go in sharps or not? And then they just do it there to be safe, rather be safe. Sorry. And when I first did research on this last semester, there's like not a lot of information, especially for vet med side of things. And so the more information we can gather and put out there, I think the better for people to use it correctly. Yes.
With your first project, there was a concern regarding the use of an autoclave in
Yes.
hazardous waste processing, where they had to have, the red biohazard bag brought into the sterile room.
Yes.
Is there, did you look into the feasibility of, some kind of process or engineering solution, like, for example, what we saw in a lot of the human hospitals, where the sterile room is physically, like, the autoclave is almost like in the wall between a dirty room and a sterile room, so you never need to enter the sterile room to input systems into the autoclave to clean them.
Interesting.
When we were looking at like the mechanics and the pipes for the autoclaves, we had to suit up in the bunny suits, go to the sterile.
Yeah.
But do you know, would that be possible in this case, some kind of physical rearrangement?
In the current central prep room, probably not, just because of space. And because, so in your scenario, were they entering things into the autoclave from the back?
No, they're the main door where you go into the autoclave with the buttons to turn it on are in a dirty room. And so you can go in and you can close it and you can do all that. And then there's other kinds of, I guess, controller maintenance stuff that's like behind it, where if you want, you could probably access the contents from that sterile room, but it's like an airlock. There's absolutely no need to bring anything dirty through the sterile room to get it to the machine.
So that's way fancier than what the vet med, any vet med thing I've seen so far, but that's really cool. I'll definitely mention it just because they are looking to redo the central prep totally. And I know they're working on redoing like surgery suites and stuff first before they get to that, but I definitely will mention that to the supervisor to go from there. Hi, yes.
Actually, it is already implemented. I had an internship at NBAF where they do a lot of large animal studies.
Yeah.
And those type of autoclaves are actually accessible too. And I've also done entomology studies where it's supplies.
That's so cool. That's really good to know. I like that you guys brought that up so that I can suggest that too. Vet med, like I said, is a little bit behind human med everything. So yeah, it's good to know what solutions they're using. Yes, Arthur.
Have I guess an approximation maybe from you on how much isoflurane the vet med facility goes through a year?
Yeah, so it ends up being, I know I had on my cost, it was like 777 per 2 years. So after that, 300 something,
7
vials times 250 mils.
So again, at the human hospitals, most of the ones that we went to are in rural areas that just don't do that much surgery.
Oh, gotcha.
And so, yeah, we didn't get a chance to see a benefit to trying to scavenge that. So I was just wondering, obviously you guys go through a lot
Yeah,
of facilities that we went to.
and we do. And really the most surprising thing to me was sevoflurane, because that would be a great replacement, and it's a great anesthetic gas for during procedures as well, which Chris and I talked about. It helps the patients wake up a little bit faster, they go to sleep a little bit faster. It's great. Just the price is so expensive, and if you're a surgeon, like animal health already struggles with pricing and people wanting to pay for those services. And so if you're tacking on a $96 anesthetic, people are just not going to pay for it. But it's kind of unfortunate. But yeah, we do see quite a bit of surgery and whatnot.
Mm-hmm. Hey Arthur, did you guys have a chance to look at what types of anesthetic gases they're normally using? Is it also, I have no idea if the human ones and animal ones are similar.
So
Yeah,
pretty much,
we use those two. We've also seen the use of desflurane.
Horrible. Don't do that.
And so I would say that because of the emissions, I think it's a bit higher than sevoflurane. Why would you say that?
Desflurane is the worst out of the three, and actually it's so bad that we don't use, like animal hospitals don't use it anymore. They kind of just cut that out because it wasn't, with isoflurane being such a better vapor in terms of environmental output, we decided just to completely replace desflurane with isoflurane.
Yeah.
So we've always been recommending sevoflurane. We've also seen nitrous oxide. So that's, like the laughing gas you get from the dentist office. We recommend against that just because it's in a big centralized system, got a lot of pipes running through the facility. Really hard to find leaks in those, a lot more expensive than compressed air. Why would you not?
We don't like it either. There are a couple of reasons, health-wise, but also environmental output. It's really not great. It's a little bit worse than the desflurane. So those two would be the worst. These are the two better options environmentally.
Okay.
But we can still improve.
Okay, around any other questions?
Yeah.
Yeah, so your charts project,
Yeah.
I know like you put those infographics up. Did you have
Yes.
a chance to like do another audit?
So we're going to, probably I'm a little bit weird in the sense that like my PPI internship is ending, but obviously I'm still at the vet school. So my mentor is Dr. Capaldo, who's an anesthesiologist at the vet school. And so he's asked me to kind of continue auditing and implementing and whatnot. So it's my PPI internship's ending, but I am still going to be working on this.